It is our greatest pleasure to have you all here. We welcome you on behalf of the Young Epilepsy section of the International League Against Epilepsy. And we want you to know that we have participants from all ILE regions in different training phases. Today, it's our first session, and we will have our Q&A session with Professor Van Passen. He's currently the head of the epilepsy unit of the Department of Neurology at the University Hospital Leuven and the head of the Laboratory for Epilepsy Research at KU Leuven in Belgium. He has a special interest in epilepsy surgery, the application of new imaging techniques in the evaluation of patients with intractable focal epilepsy, and more recently, in wearables for seizure detection. He is the principal investigator of CSIT-2, a multicentric study in several European hospitals that aims to evaluate a wearable device in seizure detection. He is a Belgian physician, and from 1984 to 1993, he trained in several institutions, including the Institute of Psychiatry and the Maudsley Hospital in London, also the National Hospital for Nervous Diseases, and finally at Mount Sinai in New York, where he obtained his degree as neurologist. From 1993 to 1996, he did his PhD at the University College London in the National Hospital of Neurology and Neurosurgery about quantitative magnetic resonance imaging and neuropathology of the hippocampus in temporal lobe epilepsy. Thank you very much, Professor Van Passen, for being here.
Thank you, Javier, for the nice introduction. It's a pleasure to be with you, and the format is quite new for me, so I'm looking forward to this session. Thank you.
The way we decided to do this new format that might be strange for maybe most of us is because in the following sessions, which will be hands-on, will be more practical, so everybody will have all the time to follow the steps at home or whenever they have the time to do it, and using these advanced neuroimaging techniques. Therefore, the idea is that they do it beforehand, and then afterwards we can discuss what were the problems we found, and also like open up questions, and maybe we can discuss a case or two if some of the participants have a case that might be interesting to share. And now it's time for asking some questions.
I can start if that's okay.
Okay.
Good
Thank
morning
you,
or good afternoon, wherever you are in the world. First, thanks for putting together this amazing opportunity. And it's so exciting to see the list of people and see names from all over the world. I think this is a great endeavor. So thank you for that. Professor Passen, I really appreciated your showing us the different cases. I think there were like 12 cases, and I think you really convinced me on the use of Akai and AMAP and PET. And I was doing a quick search, and this might come when we do the quantitative PET module, but I was wondering if the software that processes the Akai maps is freely available. Is that something that we can have access to? Or is that proprietary
no,
software?
It's not freely available, but I think Avi Kleren, who is working with us, will give a talk on the more technical aspects. And the idea would be that if you are interested, you could get it, and that you would be able to use it actually. Absolutely.
Sounds good. That would be great. And then I had a question, and maybe that's a difference of how we do it at our side, but I think at least for 2 or 3 of your cases, you talked about 3 specs.
Yes.
For a single patient. I don't know if you can share how you guys go about doing that. You do 3
well,
different...
we have I think the main problem is having the tracer on site, and we have a magnificent nuclear medicine department who initially made it themselves, and I think they buy it now, but they have an agreement where they can get it quite cheap. So then it's easy to have it available, and we have it from 8:30 in the morning till 5, and you have to wait at least 36 hours when you do a SPECT on Monday, for instance. You can repeat it on Wednesday, and then you can repeat it on Fridays. So ideally, in a week's time, you could obtain it 3 times. So, and
so
on
the same
occasions,
injection, you're scanning them perhaps 3 different times after each injection?
Well, you have to give an injection, do the scan, and then the tracer in your body for
yeah, it decays after 4 hours.
Has to decay, and you can repeat it in 36 hours. And then the thing is, you have always another seizure, and a seizure type where you inject, you don't know, will it be a focal seizure, impaired awareness with generalization. The timing is important. So, and when you have several specs, you can select the best one. And once you have some experience, you will see that it really depends on the time of injection, the type of seizure, that you get propagated patterns. And the idea is the smaller the seizure and the sooner you inject, you get more focal information.
Please, Robert.
Let me unmute myself. First of all, thank you also for this nice overview of the clinical imaging. I was wondering, because you are also using the Huppert's software for
Yes.
detection of FCD, right?
Yep.
And I was wondering whether you know of any other good softwares that are freely available. So there is the MELD project that came out, I think last year, right? And they published their code that everyone can use and implement. So my question would be if you know of any other freely available or better accessible software to detect FCDs, actually.
The answer is no. We have been using Hans-Jürgen Huppert's method for, I think, as soon as it came out. We got it for free, but I think that for several centers he charges because it takes a lot of time for him to get the control database in order, and it's taking time for him.
Robert, the idea is that in a few weeks, we're also going to discuss the MELD project. So Konrad is going to be here and they will guide us through the process. And hopefully we're going to have a guideline on how to do it. Also, we're going to discuss the Montreal Neurological Institute pipeline for focal cortical dysplasia. So Professor Andrea Bernasconi is recording a lecture about focal cortical dysplasia using also 3 types of elements, about the texture, the junction, and they will explain everything. And also we will have a Q&A session, and they will send us the link so we can download it and analyze all this or use these pipelines with our patients' data. So this is the main goal of the course, is that in the end, we have the basics so we can do it ourselves with our patients. I saw one hand that was on. I think it was Jose. Thank you very much, Jose.
Yes, thank you very much for being here. And thank you, Professor. I just would like to ask a question. It's about a SYSCOM. I have seen a lot of clinical variability in the Z-score, in the preference about the Z-score and the SYSCOM. So in your experience, what is the best cutoff value of the Z-score for SYSCOM?
You mentioned SYSCOM.
Yes.
Well, it gives you an idea of perfusion changes during a seizure. There are several ways to look at it. What we do is just subtract and then look at the Z-scores within the image. There is also a statistical method whereby you can compare this with control database and then look at statistical differences. There may be some advantage to that, but I found SYSCOM quite useful, actually.
I was thinking about precisely the Z-score. Some centers use 2.5, some centers use 2.0, and other centers use 2.5. So I'm just wondering if there's any mean value which could be useful?
It depends. We usually use Z-score of 2, but we also use 1.5. It's also fun to use it without any thresholding, that you see where is the hypoperfused regions and the increased perfusion regions. Sometimes when you have a postictal SPECT, I only look at the hypoperfused regions. So if you look at how SPECT evolved, the first SPECTs were done, I think, a few decades ago, and they had to reconstitute the tracer at the bedside. So it took 1 to 2 minutes to get your tracer ready. At that point, the seizure usually had stopped, and at least this was with the Australian group, so they had all postictal SPECTs. And then they just looked at hypoperfused regions, but that's certainly not as sensitive. So I think once you have SPECT available, I think it's a way of playing around, and there is no really one Z-score you should stick to. You can look at it and to get a flavor of, so you see usually the ICT-Lancet zone, but also lots of hyperperfused regions which represent propagated activity. And to get a flavor of that, I play with several thresholds.
Thank you so much, Professor.
Yeah, but can I ask a question?
Please, Ajay.
Thank you again for the wonderful lecture. I had 2 questions about PET. One is there, so we are sort of wanting to see a hypoperfusion on PET, but if PET is, suppose we get a PET very close to a seizure, is it going to affect the PET metabolism?
It will, absolutely.
What is the duration that you actually
well,
postictally? Yep.
Yeah, in the literature, you find lots of things. And some people say, oh, you should wait at least 1 day after a seizure. Actually, I like to do it as close to a seizure because then the regions will be more hypometabolic. It's a functional technique. So, and I also like to try to get an ictal PET. So when you inject FDG, it takes like half an hour before the full dose is taken up in the brain. And what you see on your PET image is what happened during that half hour. So you really have to look, we do it under EEG, you should be sure there are no seizures during this half hour. But if you do, then you have a combination of an ictal PET with intraictal activity. But usually you see where the seizure is. So it's a very dynamic process when, as soon as there is ictal activity, the PET tracer is taken up much more. So again, no fast rules, hard rules. And actually in epilepsy, you can't really plan it. And when you plan a PET scan, you have to do this a couple of weeks in advance. It may be that the patient had a seizure the night before. When you know this, then you can take this into account. But in my experience, then it's more hypometabolic because it has to recover. It's a sort of, I see it as a type of inhibition, probably.
Yeah, thank you. Thank you, sir.
I think something that might be important, or maybe Professor van Passen can tell us about, in several countries, it's not possible to have SPECT all the time. And it's so taking this into consideration, what would be your recommendation for using SPECT? Like, for example, trying to withdraw all the medication, for example, if the patient is admitted on Monday, maybe that by Wednesday.
Well, like we have several, like the people in Utrecht in the Netherlands, which is a big epilepsy surgery center, they have SPECT available for 1 day. So they select their patients with daily seizures. Then you just select these. And when that's not possible, they send them to us because we have SPECT available for the full week. So I would start with that, select your patients with daily seizures, usually frontal lobe seizures, but then the problem is they are usually during the night when they are sleeping. Then you have to switch your patient and have them sleep during the day, and then it works out well. So yes, you have to do some planning, and once you have SPECT available, I would go for it. I think it's a very useful technique.
Also, taking into consideration the multimodal possibilities, in some countries it's not possible because we have here people from all the all the regions. It's not possible to have all the modalities at the same time. Which one would you say, if somebody's thinking about working with some colleagues in opening a surgical center?
What I would say is use the modalities you have. We don't have MEC. We have a MEC one in Brussels, and when we really need it, we send them to there. We don't have a 7 Tesla. When we need it, we send them to Maastricht in the Netherlands. So you should look at what do we have and how can we optimize this. I would certainly, you should have MR. Morphometry would be high on my list to get more subtle dysplasias out of the system. And from the functional techniques, I would go for PET and or SPECT. PET is the more easy one because it's an intricate study. SPECT, you really have to have the setup and have a nursing team who are on standby and can watch the patient all the time, because you really need early injections. So logistically, that's the more difficult technique.
Leksha, please.
Okay, thank you. Thank you very much, Professor, for your wonderful lecture. I was actually really impressed with the number of SPECTs you are performing. If I get it well, it's like 80% of all patients passing pre-surgical evaluation are having SPECT. Is that right? Is that correct?
That's right, yes.
That's enormous number, actually. My question is, do all the patients need to have SPECT, actually? Because I'm coming from Serbia, for a relatively small and young pre-surgical evaluation center. We operated something like 200 patients for 15 years. At the beginning, we performed SPECT, but we found that it's actually a really complicated and unpractical method.
Yes.
And we had to import actually the radiopharma from Hungary. We had to wait for patient to have seizure near the bed, etc. So it was really complicated to applicate the radiopharmac, actually. So we actually give up from that procedure, because we found that there's plenty of more patients we could operate without the SPECT. So
absolutely.
My question is, what are the number of how the SPECT increase the number of surgical candidates?
That's a good question. The answer is you don't need SPECT all the time. And there are plenty of patients when you have a good MR and a good video EEG recording, even without PET, that you can probably say we have enough data to go ahead and everything looks concordant. SPECT is very useful, I think, when your scan is negative, the MR negatives, and ideally subtle dysplastic lesions, which the SPECT can help you to pick them out. I've given you several examples for that. So I think SPECT can really help you with these initially looking MR negative cases, which turn out to have really something. So I would, if you would have availability for SPECT and have to select them, go for these more difficult cases.
Yeah, I understand. So in your opinion, or maybe you have data, what is the percent of increased successful rate of surgery by using the SPECT?
Yeah, I would say 10 to 20% of cases where it really made a clear difference.
Well, yeah, that's a significant number. Thank you, Professor.
Please, Juan, yeah, feel free.
Thank you. And thank you, Professor, for your great lecture. And thank you to the organizers for this wonderful course. I've been waiting for this for a while, and it just suddenly happened. So thank you for letting me be part of it. Professor, switching back to structural imaging, my question is, I'll try to see if I can make sense out of it. What do you think that the introduction of the morphometric analysis and now the MELT project and the texture pipeline, it's been around for a while, and do you think this new imaging has drastically changed your workflow into selecting patients for surgery? Or is it still something that you think it needs, it's great for research, has a lot of potential, but still needs to be worked through? You mentioned in your lecture, if I'm not wrong, one of those study showing the transition from just basic imaging into specialized epilepsy protocols being reviewed by specialized.
Yes, the BOND study.
Yeah, yes. And the numbers changed drastically, right? Like really flipped totally from negative MRIs to almost rarely negative MRIs. I think it was like 10% or something.
Yes.
For the latter. So considering that even when we have specialized neuroradiologists, sometimes we don't get those numbers of finding things, and sometimes neuroradiologists see things that you have to kind of believe them, because it's hard to see, even if you're sitting down with them and trying to understand what they are pointing at. But I guess overall, what was your experience with this with these new techniques, and has it really drastically changed your practice? Or
yeah, the answer is yes, definitely. So the point I wanted to make with this first study with MR, which I called the mental co-registration. Once you tell a radiologist, look at the left temporal lobe, because we know from our video EEG that it starts in the left temporal lobe, they focus on that region, and all of a sudden they see things that they overlooked. And it's over and over again that with other imaging modalities, once you optimize them, you start to see things that you didn't see before. And this is certainly true with small dysplastic lesions. And I've given you several examples where, even with hindsight, I mean, I showed this case with this insular trap, which with the clear-cut hippocampal sclerosis, when you just had video EEG, you just would go for the hippocampal sclerosis, but you have these cases which actually are extratemporal lobe epilepsies with concomitant hippocampal sclerosis. With these techniques, you pick them out now. So that's what I routinely do, to look for subtleties that help you to get different scenarios out of a case. So yes, once you have these techniques, and it's difficult to get this in actually a publication. We are looking at it to, and I mentioned this, we need much more publications. If you look, John Duncan looked at, I mentioned this study, at the prognostic factors. And when you look at imaging, it's the SYSCOM, which has been around for 3 decades. And then the concordance between what you see on the MR and the EEG, which is a type of also co-registration. You can actually co-register your EEG. But it's obvious to me, using these techniques, that when you combine them, you see things that you haven't seen before, and which makes it very clear. And I mentioned several patients from the Netherlands who were looked at by experienced epileptologists. And when we use our techniques, I tell them now, send your PET data, and we do the SPECT. And I sent them back with all these images co-registered and tell them, for instance, we had a case a couple of months ago where I thought, well, this is a subtle dysplastic lesion. They thought it was a temporal lobe epilepsy, but the dysplastic lesion was in the frontal lobe and it propagated to the temporal lobe. They just operated the case and the patient became seizure-free. So having seen, get the patients to our center for SPECT, and we got lots of them from Queen Square at one point. I know what the struggles are and what the functional imaging has to offer. So once you have it, I would actually try and get it. And then you have to optimize everything. You have to have a person who does all the co-registrations, which is also rather time consuming. But if you want to, we can provide you all the algorithms. We now do it in an automated way, and we can provide you all these scripts that run the co-registration in an automated way. And then you have these images. But I think Evie Claren will discuss this, and she does this in our center, and she can provide you all these details.
Thank you, Doctor. And if I may follow up with another question, you mentioned the Insula case, the insular trap. We here, I'm biased because we used more of the texture. We have more experience trying the texture pipeline than the others. But one of the caveats for that is actually the insula. Even Dr. Well, I guess Dr. Bernasconi will comment on that. But the insula has not been easy to look at for subtle lesions. And so can you comment on that for other techniques of structural imaging?
Do you mean structural imaging?
Oh, for structural imaging, yes, in the insula, which tends to be a little hard to see.
It is. I mean, I told you I just use visual assessment. We have this morphometric analysis. I don't have any other. Bernasconi, I think they have other techniques, but they will talk about that. And I think you should try and get your hands on one of these algorithms. Insula is a very difficult region. Very often you don't see dysplastic lesions. And even with functional imaging techniques like SPECT, it's a region that propagates very fast. Even people who do lots of stereo EEG studies, what I understand from them is that you pick it up within a fraction of a second on the other side. And that's what we see also on SPECT. You see blobs on the two sides, and you can't tell where it starts. So it tells you the same thing, actually. That the propagation is fast.
Thank you.
Robert.
Yeah, I have just one comment on that and then a question. And I think what is great with all these multimodal, with a multimodal setup is that you wash out the human error, right, in a way, because so I did 1 year in neuroradiology, and the reading could have been completely different with the different attending. Like some of them looked in MRI for 30 seconds, and then they said, well, she doesn't have anything. And the others really took time and care. Even in stroke, that was tremendous. And I find it kind of reassuring if the patient's destiny doesn't really depend on just one person or one modality. So I think it's cool to get that we have the opportunities to use those. One question, a practical question actually would be, who is doing all the post-processing and the analyses? Is it the neuroradiologist? Is it a very, I don't know, motivated neurology resident? How do you organize this?
It's a very good question, because it, as you mentioned, it's a combination of imaging techniques. You typically have the neuroradiologists who don't do it. The nuclear medicine people don't do the co-registrations. In the end, we came up with a solution that the person who does it, she has actually had obtained a PhD in epilepsy. She's a biomedical person, and she does all the co-registrations. And it took a while to convince the radiology department, nuclear medicine department, but they all agree that it's useful, that, and it's actually in the neurologist's hands. So, and I look at these images myself because I think it's great. I know what the patient has. I know the CG semiology. I know what the EG show, ictal, interictal, and I have access to the best imaging. So you get everything together. So this idea of you have your different zones and you try, it's a puzzle. And the more I'm involved in epilepsy surgery, easy cases are usually the low-grade tumors. In my experience, are easy cases. The other cases tend to be actually quite complicated to get your jigsaw puzzle into one place. And you need everything you have. And also another important point, you have to visually confirm what you think is the case. So we often, when we think, okay, MR negative case, we get our multimodal image, I make a screenshot and I send it back to the radiologist and say, well, we think there is something there, or we don't see it, or there is something subtle. Can you please review? And they have that big, nice screens with a much better resolution than we have, and they can look at it. And very often they say, oh, yes, that's correct. Now we see a small dysplastic lesion there.
Yeah.
And if not, we try and get a 7 Tesla MR.
That's also my experience. Like very often, you just get an MRI that asks for epileptic focus.
Yep.
And at least many neuroradiologists that I have got to know, they don't make the effort to go through the whole patient history, look at what epilepsy is suspected. Also because it's different systems, right? You have the PACS and then you have your clinical system. I don't know. So I think it's good to like ask the very specific question from the beginning, sit down with them.
I think what Robert and Professor Van Passen mentioned it's very important. It's that you have to communicate with your team, and when you're doing it, you have to create a team, because this cannot be done by one person. Not even if they have only or the time for doing it and only dedicated to it is not possible, because of course every member of the team has different expertise. And the idea is that you can combine the expertise to like create a positive result for the patient. And of course, that's also very important is to have, and Professor Bernasconi will talk, Neda Bernasconi will talk about that next week, is about the protocol, like even for a structural MRI, the protocol is very important, because most of the time, if the protocol is not appropriate, we will lose a lot of information. You have a very small dysplastic lesion, you say, then you won't be able to see it. So that's the reason we should, I mean, as a clinician, whether you are the neurologist or the neurosurgeon, you should also look at the raw data, if you want to call it in that way. That's very important, because that would give you more information if you just trust in the neuroradiologist. Of course, you have to trust them, but I mean, sometimes you have to take a look at it by yourself. Professor Van Passen, thank you very much for being here with us. Thank you very much for taking all the time you took to prepare this lecture, for recording it, and for giving it to us.
Take care.